If everybody could take their seats, we're going to start our conference here in about a minute.
So you registered and checked in? Oh, no. Okay, let me check you in. That way you can get it.
Caitlin.
Oh, yeah, right down. Right next to me. It was just beautiful. My coworkers got to see me flat on the sidewalk.
Are you going to need a lavalier mic at any point?
Tomorrow they'll have to use the lavalier. They said they can't really use it today, right?
Okay.
But you
Okay.
can take this off. You can take this off if you need to. Good morning, everybody.
Good morning.
Welcome to SCCAPE. We're so excited to have you here today. My name is Shirley Johnson. I'm one of the co-facilitators for the conference. As we're going throughout the next couple days, you're going to meet all of our team, but I just want to give a shout out real quick to a couple people who without this, I would not be able to pull this together myself. My first colleague here is Daniel Sopp. He's known as our digital dynamo. If we have any technological issues, he will go ahead and solve those for us. And back there at the door is Joan Quarter-Mabe, who is also my counter co-facilitator partner in crime. So without them, we would not be able to put this together. Someone that's not here today is Jessica Capano, and she is actually a Henrico teacher, and for the summer, she was able to come in and help us pull together all of our graphics and all of our information. So even though she's not here, I'd like to give her a quick round of applause. So a couple housekeeping issues. One that's really significant, especially for those of you that are looking for CEUs or CMEs. Each session, you will be asked to be scanned back in. So when you leave to go to the restrooms, you're fine. But when you come back in for like a next session, make sure that who's ever at the door is scanning your badge. For tomorrow's sessions, there's not always a break in between those sessions. So there'll be table numbers tomorrow, and staff know what tables to come in and scan you in. If for some reason we miss you, please make sure you raise your hand or you go back out and get your badge scanned. Otherwise, you're not going to get credit for that session. You have about a 15-minute window that if you're late for a session, you could still scan in, but after about 15 minutes, you will not be able to scan in for that session. We have plenty of lunch and breaks built into this, and we also have some really fun activities. So we're hoping that you will get excited with us, get up and move when we ask you to. I know we're a little cramped here today. Tomorrow and Thursday, we're actually going to be in the conference rooms in the front, so there'll be a little bit more room there. But when we ask you to get up and move, don't be shy. Get up, shake your booty, keep you moving, keep the juices flowing, and we hope you really enjoy that. There is an evaluation form in that big, thick binder. Now, when we were checking in, there was a little bit of confusion. So anybody that's here for the 4-day conference that did not get a portfolio, you need to go back out to the front desk and let them know. If you got a portfolio and a bag with another binder book in it, please return that binder book to the front desk. So you should only each have one binder per person that's attending. Your evaluation form is in the binder. You're not going to turn that in until the actual end of the time that you're here for the program, but because there's 20-some sessions here in the next 3 or 4 days, after the end of each session, if you do want to go in and do your evaluation and kind of keep things going, then you could do that, and then when you're ready to leave, you can turn those evaluations in. So as we get going, we wanted to introduce you a little bit to the VCU Sickle Cell Adult Program. We do have a pediatric program here, and some of our staff will be speaking with you throughout the session. But in order to kind of give you a highlight of what we do here at VCU, we did a little welcome video. So you'll see some of our staff in the video, and then you'll meet some of them throughout the course of the conference. So hopefully I do this right. We have several conflicts of interest, as you can see up there. Oh, I guess I'm a little behind. All right, what do I do?
About 2016, we noticed after having a fairly small staff that patients were growing. The number of ED admissions, ED visits was going up to the point that it was actually twice in 2017 what it was in 2014. We also noticed that people were staying in the hospital a little bit longer. So all the metrics that one would use to judge the quality of care for patients with sickle cell disease were going in the wrong direction. We did a lot of analysis. We put pen to paper about the kinds of staff we needed, and we made a proposal to the hospital to develop what we're calling the adult sickle cell medical home.
Care in the United States healthcare system is often fragmented, and when care is fragmented, it leaves patients to coordinate their own care. And unsurprisingly, in that kind of system, patients have poor outcomes and often feel unsatisfied with the care that they receive. And that's especially a problem for people with sickle cell disease. And so I felt that we had an opportunity at VCU to address those challenges. I reached out to Dr. Smith several years ago when I recognized that there was an opportunity to improve coordination of care across the department for patients with sickle cell disease, because he's long been the leader of our sickle cell specialty clinic. And so we've been working together for about 4 years now to try to improve and try to build a medical home.
These adult patients with sickle cell disease nationally are neglected because this was a childhood disease where suddenly the patient started living longer because of good childhood care. You know, treating a child with sickle cell disease really is focused on helping them survive childhood. You are talking about strokes and infections that kill children. Treating patients in adulthood is about treating pain, because the patients develop early failure of major organs from poor blood flow because of the sickle cell disease. And that's a totally different animal than treating children.
When we first started the project, we looked at guidelines to see how we could improve our care based on expert and evidence-based recommendations. And one of the things that we found was that we needed to make sure that when a patient presented to the emergency department in a pain crisis, that we were getting them adequate analgesia in recommended time frames from triage or from registration.
And so what we've seen over the past 6 years is just this really growth of the clinic. So we actually have people that can help with getting patients' medications filled. We have social workers, we have somebody that can help us on our research side, and then just having patient navigators, so just having somebody that can actually talk to the patients, be with the patients through the whole process, whether it's in the emergency room, when they get admitted in the hospital, and when they get discharged and go home. Being able to say that we have a clinic that is able to touch that patient along that spectrum is very new to us and really is exciting.
And then we have our patient navigator program, which has really been significant in helping to reduce the cost for things that we're doing here today. They go out and see them in the community, they see them in libraries, they go down and see them in the emergency room when they come in, they see them in the clinic, they go see them in the hospital. So they build this trust relationship with patients, and they are the first person that the patient usually will contact now when they're having problems. They're crucial to not only the program, but to the patient.
Yeah, a lot of these patients wouldn't be doing as well as they are without their involvement, so it's huge.
And the patients agree with us. You can see patients smiling more when they came to clinic now, feeling even when they came to the emergency department and to the hospital like, oh, somebody knows me. And there's an individualized care plan there for them with their name on it, so that the physicians there, even if they don't know the patients, have something to refer to. Oh, you're Dr. Smith's patient. This is what we're going to do for you. It gave the patient a lot of relief. It gave the physicians a lot of relief. They didn't feel like they knew what to do for some of these patients, especially with regard to opioids. And you know about the opioid epidemic. It is rampant now. And these patients are really not a part of that. Their need for opioids was legitimate. Their use of opioids was high, but people were suspicious. And so this removes some of the stigma, removes some of the suspicion around needing opioids and using opioids, especially in the emergency room and in the hospital setting.
2020, I think, will be exciting because our hope is that there's going to be a new infusion drug getting approved pretty soon. We can offer any new drug that comes available, and that's the future of sickle cell disease.
I've been incredibly surprised at how quickly the Patient-Centered Medical Home has been able to improve outcomes for our patients. In only 2 years, they have decreased inpatient days by over half. They've dramatically decreased readmissions and length of stay, and most importantly, the people involved in caring for our patients and the patients themselves feel that our system is the way that it should be, that we're able to provide care that's not just focused on someone's disease, but really the whole person, and I think that's a wonderful thing.
I would really like to continue to see the success of the patients that we feel are in homeless situations and continuing to work with the community to try to get them into stable housing and help them to become more successful in their quality of life, which in turn then should help them stay stable with their disease.
I don't know how many patients have told me, I feel like I'm actually getting really good care. You guys know what's going on, you talk to each other, you help me out, you call me, you check on me, and I feel like no matter where I am in clinic, the ER, inpatient, you're going to be there. Hey, how are you? What's going on? How can we help?
So from my perspective, I think I'm really looking forward to where the program grows, new patient navigators, new staff members, and I'm really excited to see the future for the sickle cell program.
My number one excitement for this program is that patients feel human. They feel cared for. It's an adult sickle cell medical home. A few patients have been cured with bone marrow transplantation. We look forward to genetic engineering to cure our patients in the near future. We have a program and a research protocol that we're opening there. And we're doing research to disseminate our results to the research community and to hospitals around the country so that they can replicate programs like ours. Celebrate life and lessen the pain. Celebrate life and lessen the pain. And that's what we're doing, making the pain diminish and helping people become able to live a healthier life.
So ladies and gentlemen, standing in the doorway is most of my team. If you could just please give them a round of applause. So I think that Dr. Smith really kind of summed this all up. We want to celebrate life this week. We want to lessen the pain. We want to give you all the tools that you need to help care for patients with sickle cell disease. So now I would like to go forward and introduce you to Dr. Wally Smith. He is the first recipient of the Florence Neal Cooper Smith Professor of Sickle Cell Disease, second African American chair in the United States, right behind Maya Angelou, I might add, so I think that's pretty impressive. He also serves as the Vice Chairman for Research of the Division of General Internal Medicine and is a former Scientific Director of the Center on Health Disparities at Virginia Commonwealth University. Dr. Smith was instrumental in taking a pilot program demonstrating feasibility and limited success in the VCU Sickle Cell Medical Home, which was funded in 2018. The newly established team set out to achieve the Institute for Healthcare Improvement Triple Aim for Adults with the Sickle Cell Disease Program, improving the patient experience of care, including quality and satisfaction, improving the health of the population, and reducing the per capita cost of the healthcare psychosocial determinants of health. And I just would like to say our first year, we saved $1.4 million to the institution by providing them the care that they needed. Dr. Smith is now part of the NIH Healing to End Addiction Long-Term HEAL Initiative multidisciplinary work group. This working group will provide input on HEAL research and develop draft recommendations to help ensure that the HEAL initiative meets its bold goals. Since 2012, he has served as the PI of likely the first ever randomized controlled trial of implementation science in sickle cell disease, started healing in patients with hydroxyurea. Dr. Smith also participated in the AAAPT, which is an evidence-based classification system for chronic sickle cell disease pain. It was constructed for the analgesic, and ananestic, and addiction clinical trial translations, innovations, opportunity, and Networks American Pain Society Pain Taxonomy Initiative. That's a mouthful. Whose main objective was to identify and characterize the criteria for diagnosing painful idiopathic SFNs. He has authored over 100 publications and has served as the investigator on over 50 external funded grants and contracts, including principal investigator on 26 federal or foundation funded grants. It is my pleasure to introduce you to Dr. Wally Smith.
Thanks, Mom. How many of you have between 1 and 5 sickle cell patients that you know or care for? Between 1 and 5. Between 1 and 5. Okay. Don't take your hands down. I'd like to get a count of that. She got 26 and you got 34. Try it one more time.
Hands up.
I'm making a point.
28.
Okay. What's my point? Most people caring for patients with sickle cell disease are taking care of few sickle cell patients. What's the issue? The issue is your experience is your experience, and you might extrapolate it wrongly to the experience that all sickle cell patients have. Because your 1 or your 2 is either very sick or very well, you may draw wrong conclusions. All right, now what about the pros? How many people are taking care of 5 or more? More than I expected. Okay, so I've got a challenge. Those of you who take care of less than 5, talk to the people who take care of more than 5. During the breaks, share experiences. You may learn some things. You may find that some of the erratic experiences that you've had really are not common. Or maybe they are common. But we can learn from one another here in this group. We're going to go ahead and introduce one another. So let's start at this table. Tell us who you are. Don't give us a novel. Two sentences. Where are you from?
Yeah, my name is Sherry Gatewood. I am from Baltimore, Maryland. I'm a community health worker in a sickle cell infusion center at Johns Hopkins Hospital.
Okay, so we're going to start a tradition, right? We're going to, at that chant, you're never going to forget it, because we're going to say that however many times there are people in this room. So at the end of people's introduction, we're going to say, what? Celebrate life, lessen the pain. That's the challenge to you. Celebrate life and lessen the pain. Okay, got it? We're going to challenge each other. Go.
Good morning, everyone. My name is VCU I'm the communications coordinator for Synergy and community health worker at Johns Hopkins University as well. And both my husband and my daughter suffer from sickle cell disease. And
We're gonna, no, we're telling you to do that.
oh, okay.
Okay, so everybody, let's tell her. Celebrate life. Okay.
Good morning, I'm Teresa Radford, I'm a nurse navigator at the University of Virginia Medical Center. I'm focusing on high needs patients that have multiple admissions to the hospital and probably care for about 10 patients with sickle cell.
Celebrate life.
Hi, I'm Charlene Sayer. I'm an LPN. I work at Charleston Area Medical Center. We are new to this. We are just getting our sickle cell clinic off the ground, so I'm going to be a sponge here today and hopefully take back a lot of information to help our clinic get going.
Celebrate life. Lessen the pain.
I'm Linda Davis. I'm a social worker at Charleston Area Medical Center. I work mostly in the outreach clinic, and as Charlene said, we're really new, and I want to be a sponge also. I'd like to talk with the social workers in the meantime, help the word out about the clinic. And as you know, we're of course a little state.
Celebrate life. Lessen the pain.
My name is Dr. Linda Merriweather. I'm the nurse case manager for Johns Hopkins Sickle Cell Program, and I developed the case management model in 2010 for a small hospital system in Montgomery, Alabama.
Okay.
Then I was the first nurse case
Celebrate life, lessen the pain. I'm from Alabama, so Montgomery's near to my heart.
I'm Essie Turner, I work at VCU. I'm a clinical research nurse, and I actually work in the department of
Celebrate life, lessen the pain.
Hi, my name is Donna Bills. I'm a nurse clinician. I work at VCU. We, this is my partner, she'll tell you about her. But we split our time between research and doing sickle cell day hospital pain treatment for crisis. So in the mornings, we're usually doing research. In the afternoons, we're usually taking care of our sickle cell patients. So we're split between ECD and Vidant Medical Center.
Celebrate life, lessen the pain. She got relieved in the TAM.
My name is Sierra Austin. I'm from the Children's Hospital, Philadelphia, the VCU Health worker in our sickle cell operations center, and I'm also the director of operations for Crescent Television.
Celebrate life, lessen the pain. Yes, sir.
Hi everyone, I'm Kyle Smith from Philadelphia, also Executive Director for Crescent Foundation, focusing on advocating and supporting those adults living with sickle cell disease. And I am here to learn more, and especially as a trainers and implement these programs within our community.
Celebrate life, lessen the pain.
Hello, my name is Caroline Mers. I'm a postdoctoral fellow in clinical health psychology here at VCU.
Celebrate life, lessen the pain.
My name is Lila Islam. I'm a clinical health psychologist here at VCU.
Celebrate life, lessen the pain.
Good morning, everyone. My name is Steve Wineland. I'm a clinical health psychologist here at VCU and do a lot of work with non-pharmacologic strategies also.
Celebrate life, lessen the pain.
Good morning, everyone. My name is Francine Baker. I'm with the Maryland Sickle Cell Disease Association of America. I have 2 children that have sickle cell disease, and I'm a patient parent advocate.
Oh. Celebrate life, lessen the pain.
I'm Jennifer Newland, and I work here at VCU in the pediatric clinic. I'm a physician assistant, and we have about 320 patients here at VCU that I care for.
Thank you for celebrating life and lessening the pain.
And I'm India Sisler. I'm the pediatric physician for the program here at VCU.
Celebrate life and lessen the pain. That's the A team.
Hi, I'm Shamari Kamardi, and I am the sickle cell statewide coordinator for Virginia at the Virginia Department of Health.
Can you make your announcement yet?
Not yet.
Oh! You're kidding.
On Thursday, I can.
Oh my God. All right. Celebrate life and lessen the pain.
Good morning, I'm Deshonda Greenwood. I'm from Detroit, working at Children's Hospital in the pediatric.
Celebrate life and lessen the pain.
Hello, my name is Janiqua Turner, and I'm an adult sickle cell patient here at VCU.
Stand up. Applause. And she is celebrating life and lessening her pain. Yes.
Good morning. I'm Kirsten Drucker. I'm a pediatric psychology postdoctoral fellow with the pediatric hemo department.
Celebrate life, lessen the pain.
Hi, I'm Alicia Leisure. I'm a social worker in the pediatric sickle cell clinic.
Celebrate life, lessen the pain. In the back.
Judy Anderson, Sickle Cell Association in Norfolk, Virginia.
Judy's an old pro. I think she was in sickle cell before I was.
Yes.
I think that's right.
Well, you came here as a
I forgot about the word old. I can't use that when I talk about women. Sorry about that. Julie's seasoned.
Yeah. Thank you.
Okay. Celebrate life, lessen the pain.
Good morning, I'm Victoria Rogalski. I am an MSW intern with the Sickle Cell Clinic at VCU Health. I'm brand new, I just started, so I'm just here to learn as much as I can.
Celebrate life, lessen the pain.
Good morning, my name is Elena Wade. I'm also a social work intern with VCU Health, and I work with Shirley and the Sickle Cell team.
So I'm just happy to be here and learning more.
Celebrate life, lessen the pain.
Good morning. I'm Diane Creekmore, and I'm a parent and a grandparent of persons living and surviving sickle cell. I am a patient and advocate as well, and I'm here to learn, and was invited by Ms. Judy Anderson.
Celebrate life, lessen the pain.
Hi, I'm Lakia Parker. I work at the Children's Hospital of the King's Daughter in Norfolk, Virginia. In our pediatrics, we see about 500 plus patients.
Wow. Celebrate life, lessen the pain.
Hello, my name is Harnetta Haynes. I am one of the sickle cell nurse coordinators at CHKB.
Celebrate life, lessen the pain.
I'm Christy Smith. I am with Piedmont Health Services and Sickle Cell Agency in Charlotte, North Carolina. I am a sickle cell health educator, case manager.
Celebrate life, lessen the pain.
Hello, I'm Tamika Ashford. I'm with Piedmont Health Services and Sickle Cell Agency out of the Goldsboro office, North Carolina, community health worker.
Celebrate life, lessen the pain.
Good morning, Marsha Newsom, Piedmont Health Services also, the only CBO in the state of North Carolina serving 22 counties and hundreds of sickle cell
Beautiful.
survivors.
North Carolina has a very well organized public health infrastructure, perhaps the only state in the country like it, with regionalized centers of excellence, with community health workers, each region organized to take care of patients with sickle cell disease, assigned to the patients with sickle cell disease. Only Brazil is as well organized as I'm not kidding you. Brazil is that well organized. They know how many patients they have. They have it divided by regions. They have hospitals in each region. Brazil is ahead of the United States, and North Carolina is ahead of the rest of the nation. Celebrate life, lessen the pain.
Hi, good morning, everyone. My name is Shamika Mosley. I'm a licensed clinical social worker with Atrium Health Levine Cancer Institute, Dr. Iffy's clinic, and we serve about 400 patients, adult patients, and I've been here about a year, and I'm just absorbing information and enjoying the time.
Good. Celebrate life and lessen the pain.
Morning, Azizi Coleman, Program Director for the community-based organization Piedmont Health Services and Sickle Cell Agency in Charlotte, North Carolina.
Celebrate life, lessen the pain.
Good morning. My name is Edith Cooper-Bolden, and I am the nurse care manager for the adult sickle cell program at Atrium Health, along with Shamika and Dr. Iffy. Looking forward to all I can learn.
Celebrate life and lessen the pain.
Anita Douglas, Piedmont Health Service Sickle Cell Agency, Jacksonville, North Carolina, sickle cell case manager.
Celebrate life, lessen the pain.
Marsha Collins, Piedmont Health Services Sickle Cell Agency in Greensboro, North Carolina, social worker, sickle cell educator.
Celebrate life, lessen the pain.
Justin West, bedside nurse at VCU Health, an adult hospital medicine unit where we get a lot of sickle cell admissions.
And an advocate. He's a real advocate. He's being very humble.
I am Artisha McCoy. I'm a patient of Dr. Smith at sickle cell. It's my personal mission to be an advocate for sickle cell. And if y'all don't mind, I would like to thank you all for being so excited to be here and to see like you all really care about your sickle cell patients already. And I think, as Dr. Smith knows, like, that's really important to me to really have health professionals that really cares. Thank you.
Let's give her some love. Now we can say it. Celebrate life, lessen the pain.
I'm Bailey Arangelo. I'm the clinical nurse educator at Pediatric Specialist of Virginia in Northern Virginia. We have about 300 pediatric patients.
Okay. Great. Celebrate life, lessen the pain.
Hello, my name is Tiffany Hughes. I have 2 children with sickle cell disease, and I
Celebrate life and lessen the pain. Boy, that was humble. She didn't tell you half of what she does.
I'm Ronald Deuce Jr. I have the same 2 children. I also work under my wife supporting the region and the state in all things sickle cell.
Celebrate life and lessen the pain. Laura will come back to you. I think that's about it. Staff on the wall.
Stephanie Sams, patient navigator with the adult sickle cell clinic here at VCU.
Celebrate life, lessen the pain.
Hi everyone, I'm Caitlin McManus. I'm the nurse practitioner for the outpatient side of the adult sickle cell clinic.
Celebrate life, lessen the pain.
Hi everyone, I'm Micah Thurlis. I am the inpatient nurse practitioner for our adult sickle cell patients. I see them when they come into the hospital, and I try to catch them in the ED if I can.
Hey! That's an inside joke. Every place the patients go, we want to be there and touch them and say, when they get there, say, hey! Thank you. Celebrate life and lessen the pain. So it's my pleasure to introduce Dr. Tokozini Lopato. He's a general internist who's been here since 2009, I think that's right. Okay. Prior to that, he was caring for patients in the well-populated sickle cell state of Minnesota. 22 whole patients there, I think you told me. And spent the vast majority of his career caring for the less fortunate, the neglected patients with significant social barriers to health care, undesirable populations, if you will. He's really devoted his life to that. Worked in Boston doing that, worked in Minnesota doing that, and worked in urban community health care centers, addiction clinics, places like that. It's real important to understand that sickle cell disease fits in a milieu. We were talking this morning about sickle cell disease being like HIV in some sense, like hemophilia in some sense, in the terms of the social determinants. So Dr. Lopato brought all that experience with him to VCU and was extremely comfortable. And as you saw, is going to be directing our infusion center. He'll be talking to you a lot. And is he to come up now, or are we going to keep going? Or do I turn it back over to you? Sit down.
Here's this beautiful mugshot.
So now that we all can lift weights for the next 3 days that we're here, I would like to welcome someone who's representing the organization who helped put this conference together. Global Blood Therapeutics is a pharmaceutical company who specializes in developing drugs for sickle cell disease. It is my pleasure to welcome Dr. Laura Pridgeon, who received her doctorate in molecular virology, immunology, and medical genetics in 2005 from The Ohio State University College of Medicine. I'm a Buckeye by heart, so. Her research focused on epigenetic modifications in human malignancies. Oh my goodness, you guys, I can't pronounce all these words. I'm not medical. She joined industry as an MSL in 2007 and has worked with solid organ and bone marrow transplantation and rare diseases, and currently is focused on sickle cell disease. Please welcome Dr. Pridgeon.
Good morning. It is a distinct pleasure to be here with all of you today. I am very thankful to be part of this conversation that is surely to take action in the days to come. I look forward to being a part of the discussion, and Global Blood Therapeutics is honored to help host a program such as this with all of you. So just a little bit about Global Blood Therapeutics. GBT was founded in 2011 and is a clinical stage biopharmaceutical company that is focused on discovering, developing, and delivering innovative therapies to provide hope to underserved patient communities. We recognize that if you want to go fast, go alone. If you want to go far, go together. And this program epitomizes everything that motto has to say. We are here together collectively to work together as patients, healthcare providers, and we're also focusing on the payer component because we know it's important to also have support for all the initiatives that are ongoing to help support the patient and sickle cell community. So I, as Shirley said, am representing GBT, proudly representing GBT, and so proud to be here with all of you today. My medical director, or the vice president actually of medical affairs, Ken Bridges, is a hematologist by training. He's written on sickle cell disease. He is a pioneer and also a partner, a true partner with the community, and he is sad that he's not able to be here. So I've asked him to send some words of acknowledgement to what the purpose and the scope is for this week ahead. He says, I congratulate you on creating this conference, Sickle Cell Care Coordination to achieve patient empowerment, and regret that a conflict prevents my attendance. The Sickle Cell Disease Care Program at the Medical College of Virginia is a beacon and a model for other efforts around the country. You have helped pave the road towards solutions for the difficulties faced by people living with sickle cell disease. To quote Sir Winston Churchill, a pessimist sees the difficulty in every opportunity, and an optimist sees the opportunity in every difficulty. I applaud you and all the attendees at this meeting for your optimism. So, in closing, I just want to say thank you to the organizers, the presenters, for your dedicated and diligent efforts to make this happen. And I want to thank all of you for being part of the discussions this week. Ask the questions. You have an amazing group of resources in this room. And I also just want to applaud each of you for being the change in the world that you want to be, that you want to see. Thank you.
So when we were developing the program, we really wanted to come up with some objectives that we thought would really help anyone from a patient to a patient advocate all the way up to those that are practicing at a PhD level. And we hope that what we are going to bring you today is going to give you all a well-rounded experience. The overall objective of this program is to provide the content needed for the participation to function as a sickle cell disease health navigator. We have, and I'm not going to go through them because I think all of you have them in your manual, but we came up with eight dedicated objectives that we are hoping to meet today, and I just want to summarize them. We want to review the sickle cell disease pathology. Even though many of you may be practicing, have been affiliated with sickle cell for a long time, we have the expertise here of Dr. Smith and Dr. Lopato, as well as our other team members, and we're hoping we can bring you some new information, some updated information that maybe you did not know or wasn't so sure about. We also want to describe the roles and responsibilities of the health navigator and working with patients diagnosed with sickle cell disease and comorbidities conditions, including psychosocial needs. This is very significant to the role that we play here as caregivers for patients with sickle cell. Many times we're out there treating the pain, we're treating the symptoms, but we're not treating the whole psychosocial dynamics that may be affiliated with the troubles and issues that they have going on in their life, and we're hoping we can shed some ideas on how to help patients with that as we move forward. We also want to just demonstrate effective communication skills. What is the most important thing that you want to do when you talk to someone? You don't want to offend someone, you want to provide them the ability to connect with you, but at the same time provide them the information that they need to make good choices of how to move forward with things that they're dealing with. Of course, our major issue that all of us are aware of and have been for many years to come is the U.S. healthcare system. Obviously, it doesn't work for people who have chronic conditions, whether it's through Medicaid or whether through biases or stigma or whatever other challenges that we're facing. The healthcare system impedes the way that we're able to practice and treat patients with chronic disease. We also want to help you develop a network of services. This is a great networking opportunity for all of you. I know we have at least 6 or 7 states that are represented here, and each of you probably do things differently. So we hope throughout the next 3 days, through our questions, our answers, your break sessions, your lunch sessions, you don't sit with everybody you know, but you go out and talk to other people that you might be able to learn something from. Of course, we need to make sure that we follow the guidelines of HIPAA and confidentiality and respect patients' privacy. And we want to explore the strategic benefits of being a health navigator on how to assist patients, obtain healthy lifestyles, and also deal with less self-conflict. And last but not least, You saw in our video our implementation of a sickle cell medical home, and we're hoping that we can bring things to those of you who are serving in academic and professional settings, some of the expertise and some of the challenges that we faced in order to develop our medical home so that maybe you can take those back to your community. Daniel? So, part of what we're going to be doing throughout the next 3 days is using something called a Mentimeter device. This is an order for you to be able to tell us without kind of revealing who you are, some of the feelings you have about the topics that we're discussing. So my digital dynamo colleague over here is going to be coming up periodically and helping us get this started. Dr. Smith?
So if you have a device, a cell phone, tablet, laptop, if you please grab it, go to mentimeter.com, and I'm going to pull up a question. It should tell you, or it will tell you, the code to log in 1 second, please.
Everybody got your phone? Code in now?
Yep.
So it's 42, as you can see at the top there, 42, 11, 63, and then hit submit. Then there's blanks for you to put a word. There's enough people in here that if you each put in 2 or 3 words, we'll get a huge word cloud. So try to make it one word that really helps it go very well. Put a whole sentence in, it doesn't really help. So everybody see the question? When you picture a patient, what do you see? Interesting. Everybody's about done? Not yet. All righty, so let's take a couple of minutes and have some dialogue. Anybody want to comment on the thought cloud there?
Someone put black person. Someone put black person as what they see. And it's a genetic disorder.
Keep going, I'm listening.
I know, that's how you do. But I mean, when you get into like, it's not just black people who are affected.
So you're saying that's kind of a stereotype, maybe?
Right.
Okay.
So then how do you get past it just being
Yeah.
black person?
Yeah, so a good statistic to help get past that stereotype, don't forget this one, there are more people in India with sickle cell disease than in almost every other continent put together, save Africa. More people in India with sickle cell disease than every other continent put together, save Africa. That's a thought. Other comments? Yes. Oh, we're getting sophisticated. So I'll just repeat what she just said. The phenotype in India is different than the phenotype, and we're going to get into that later, than the phenotype in, say, the United States or maybe sub-Saharan Africa. So if you don't know what phenotype is, ask one of your friends, and we're going to get to that. That was a good point, though. Go ahead. Other comments? Yes, Judy.
They see cured because they do not see the person usually when they're in pain, and they don't hear about it, so there's not enough public awareness.
Mm-hmm. Very good. Other comments?
I said person because all I see is a person, and when I hear comments about people with sickle cell and how they're supposed to look, bubbly, yellow eyes, big belly, and things of that, I don't see that. So I can't identify a sickle cell patient based on what I've been told there to look like. I just see a regular person. I don't know if a person sitting beside me has sickle cell or not.
Very good. Very good. Yeah, as a physician, I definitely was taught all those things you just said, and started looking for yellow eyes in all of my patients in the clinic, and when I didn't see it, I went, oh, you must not be that sick.
I wrote down special because to me, anybody who's going through any kind of a condition is special due to all the trials and
They are special.
tribulations that they have to go
Yeah.
through with their condition, no
Special.
matter whether it's sickle cell or anything else.
Yeah, special. That's a good one. Great. Toko, what did you see out of that?
So what jumps, it's interesting to see what is most pronounced. They're survivors.
You want to know my surprise today? My surprise is that that word seems to be equal to or greater than pain.
Yes.
You guys already got it. We don't need to give this conference.
And the strength it takes to live a life with this disease and live it productively and be happy, and then to have a family, and then to turn around and become an advocate for your children and do all the things that you have to do.
Yeah.
I have a 5-year-old and a 2-year-old, and there are some days when I feel like I'm drowning under the weight of taking care of my family.
Yeah.
And thank God I'm very healthy.
Yeah.
What if I had a
What if you had? What if you didn't have a spouse? Most patients with adults with sickle cell disease are single.
And I had a disease that the larger medical community doesn't want to treat and views me as a problem. That takes strength, and it takes being inspired.
Yeah. That might be my lesson for the day. Yes, Doctor.
I'm really struck by a lot of the one-off words that we see in the periphery, because I think a lot of that, I use words like brave and survivor, but I think we also need to really understand some of these negative things: isolated, misunderstood, hurt, depression, lonely. I mean, so many of those words I think are so true in our patients, and sometimes we don't acknowledge that, I think, to a degree that we need to. So although I do agree that we need to be cheerleaders and really, really celebrate patients' strengths and the fact that they're survivors, we also need to acknowledge their hurt and make sure that we are comfortable sitting in that space with them.
As well as their family members.
Yeah.
Okay. Very good. We could do one for caretakers and probably get a different cloud. What do you think? Yes.
So I know perseverance. Like I said, my daughter and my husband both had sickle cell disease, and I take care of patients at Hopkins along with Shireen. And my daughter had to have her gallbladder out. She's 7. She had to get her gallbladder out the day before her 7th birthday. And it was a really rough time for my husband and I to see her like that. And she truly understands her disease at 7 years old. But she was, she's very, she persevered through that because her lung collapsed. It was
Oh.
whole, yeah, because her body was so little. It was like a lot of stuff. But, at 7 years old, knowing her medicine of hydroxyurea, and, they already started with the jaundice at school. So,
Okay.
so.
Calling her names.
Yeah, saying, why are your eyes so yellow? And then mommy having to tell her that it's because her eyes are like the sun. So,
Yeah, I know.
yeah. So, yeah.
Very good. Well, so, yes.
So I actually put pain.
Okay.
So as a community health worker, a lot of the patients that are referred to me are the patients that need a lot of assistance to overcome social barriers. They're not adherent to medication, they're not adherent to appointments.
Yeah.
So I put pain because I can relate to all of the words around, like the depression, the lonely, the normalcy or lack of. So I can relate to both, but because of the population that I specifically work with, I think about all of the things that may not be positive, such as misunderstood, isolated, poverty, because I see a lot of that. And just to go back on the fact that somebody had put black. For me, when I see that, I can understand.
Okay.
Because here in the United States,
That's what we see.
the population that I work with, they're African American.
Yeah.
And what baffles me is the fact that there's an abundance of resources for individuals that are HIV positive.
Yeah.
And there are a lot of resources that my patients need, right?
Yeah.
Just dental care.
Dental care. Ooh.
And I can't get this stuff.
We didn't even do that, did we?
It's hard, right? Because once you get a certain age, when you have Medicaid, you don't qualify for the dental, and you have people who lack the resources, so it's not important for them to get their teeth fixed because the resources aren't there. So little things like that make me think about all negative things, But at the same time, my patients are survivors. They are, they are strong, when they have to be. But I think about the other things such as the pain and the depression, because these are the things that I want to focus on to make my patients better, to make them happier, to make them stronger, So that's my focus.
Excellent, excellent, excellent. Okay, we're having church. So, do I get to move on now? Okay, we're actually going to do some didactics. And then we shake a leg after that? Okay. Okay. Many of the things that we've introduced with the word cloud, we're going to give you in didactic form. And for those of you who have more than 5 sickle cell patients already in your practice and you already know this, don't take too long of a nap. And I'll tell you when you can wake up. There's more patients with sickle cell disease in India than there are in almost every continent of the world, save Africa. It is a disease that had 5 different genetic origins in terms of gene mutations, 5 different places where the mutation began. Sub-Saharan Africa, the most highly populated, the theory is that malaria selected out for people who had the gene, which actually gave a survival advantage if you had falciparum malaria. In the United States, that's going to be our focus for this conference, 2/3 of the patients are adults. How many people already knew that? only a few people realize that this is mostly an adult disease now. 2/3 of patients have sickle cell disease are adults. That means the pediatric system of care is excellent, and the adult system of care is not. We do not have a medical home as a nation for patients with sickle cell disease. The healthcare system was not prepared to receive all these children who had their strokes cared for, their infections cared for, and survived to adulthood. That's a problem because it has implications on the workforce and it has implications for mortality. So we estimate 100,000 people. Nobody really knows. Brazil knows. United States does not know how many sickle cell. I just keep saying it because everybody thinks of Brazil as one of those, what do they call them, nations, brick nations or something like that? Rising brick nations. Brazil, Russia, India, don't help me out, guys. It's one of them. So that means they're up and coming and we need to help them out. Well, Brazil needs to help us out. California is really bad. California, the life expectancy there is actually lower than for the rest of the country right now. The provider to patient ratio is lower in California than the rest of the nation. So a high population density, but a very, very low provider to patient ratio. So is there any wonder that the adult sickle cell mortality rate is climbing, not dropping? You got a problem, Houston. You got a problem. So all that work we did to keep those kids alive gets wasted because they become adult, they lose their insurance, they leave home, they lose their accountability, and they die. So the American Society of Hematology did a report card suggesting that on a 0 to 10 scale, access to care for sickle cell disease is about a 3.7. That training and professional education is about a 3.2. Now, if you got a 30 on a test in school, you are the laughing stock. You can't even get a 60? We're scoring 37 out of 100, 32 out of 100 on sickle cell care for adults in this country. Even if you're an oncologist, you're not caring for many sickle cell patients. Most of them, just like this audience, have somewhere between 1 and 5. And in this case, half of them said, oh, I've just got 1. And what about those guidelines that you're supposed to use to manage the patients? 35% are actually using them. What about the primary care docs? By the way, they're as snug as a bug in a rug, not wanting more patients. I'm comfortable with what I got. I don't need any more. Thank you very much. And I'm not using guidelines. I don't even know they exist. And I don't have much contact with specialists who manage my patients. So we need solutions. Here's one: improved access to care via formal transition programs such as Dr. Sisler's and our program here, where you hand the patient off formally. We do that. We have a formal handoff, sit and talk about the conference, talk about the patients. Other examples are the medical home. We fought to get that medical home. That was not a simple thing. The hospital did not want to give up those resources. But when they saw our pilot program that saved $330,000, and I said, put a 0 on there, and you could imagine how much you're saving. They go, oh, maybe we'll give you some resources. So that's how we got the program, data. And my challenge to you is set something up. If you don't have anything, Make it small and demonstrate savings, and then take that to your accountants. And everybody say backfill. Backfill is when you keep a sickle cell patient out of the hospital and open that bed up for somebody that's got huge insurance and doing a lot of procedures, et cetera, et cetera. They like that. But you need an ecosystem at its best. You need an ecosystem to care for these patients, which is why we are proponents of the hub and spoke model. Everybody can't have one of these. But every state should have at least one of these, or two or three. And we should be able to refer to the spokes who are caring for patients. You'll be able to refer to the hubs. But you need an ecosystem. So the American Society for Hematology is trying to do something about that. We started out with a comprehensive care workshop idea, and we did a needs survey. We asked, okay, ASH members, there's 27,000 ASH members, only 1,100 admit to seeing a sickle cell patient. Okay, ASH members, tell us about your interest in sickle cell disease. Well, 547 people actually took the survey or saw the survey. 160 actually started it. 80 completed it. So I'm telling you about 80 out of 27,000 people. And we asked, do you have an infusion center? Do you have a day hospital? Do you have an outpatient clinic? Do you have an inpatient clinic? Do you have a medical home or other programs? And this is what we got back. These are numbers, they should be percentages, 56%, 49%, 66%, and so forth. Do you want to do better? Well, duh, yes, I want to do better. How confident are you in your skills at doing better? Do you think you could go to starting to provide a clinic? That's probably a good place for a lot of people to start. 73% said, yeah, I think I can do that. What about leadership and change management? Well, I got to demonstrate the benefit to the hospital, show them some data, but I'll try. 56% said, yeah. What about business planning and financial analysis? Only 35% said, yeah, I know how to put a business plan together. I'm confident I can get my CFOs in the room. Laura, you want to say a word or two about this?
It's like herding cats, I imagine.
And you, in industry, have the same issue when it comes to the payers, correct?
It is a challenge because payers are not often asking for information, and they're often trying to balance their book of business. And that is an understatement. And so as a medical person, I've had a lot of really important conversations with the payers, and I know every company in the space is also in positions, are advocates, trying to help them understand and get them to see what they don't know and where their lack of information has been.
Yeah, very good. You don't know what you don't know. That's where you're starting with sickle cell disease. You don't know what you don't know. And so a lot of it is to inform people who are holding the purse strings about benefits to them and their job and their bottom line. It's talking green, not black and white here. And you're out there providing compassion and good care. You get the point? It's a whole nother world out there that you have to communicate with in order to have a good sickle cell program. I'm just saying it up front. And so we can't ignore the almighty dollar. Do you want help to do this? Yes. And do you want coaching? Yeah, okay, I'll take some. So if you haven't figured it out yet, patients are not getting what they need. This is a thought experiment I did, imagining 77,000 patients with sickle cell disease, imagining that about 50,000 or so might get to seek professional care and find it, and maybe 10,000 or so might actually get to see a specialist. And then hydroxyurea, which at the time was the only drug available for sickle cell disease. It's life-saving, by the way. 28% of our patients were on it. So if you do the math, that means out of that 77,000 patients, 2,800 actually got life-saving treatment. Not so good math. Daniel. Is that the right one?
No, this was the next one. Is this the one? Yep.
Yep. Okay, pull your phones out. And we're going to that same website that might already be pulled up. Hit refresh.
If it doesn't come up, it might be the different code, 4827.
Oh, you gotta put a different code in, so you gotta
Go
go
back.
back
Yes.
and put a different code in. 4827. Hit submit. Very good. 4827, and you should get a slide bar, and you can use your finger to slide. On a scale of 1 to 10, looking at the picture, please rate the quality of adult sickle cell medical home for the patients you know and care for. So those of you who have 1Bs and 5Bs, especially, I want to see what you get. Wish we could divide it up by that. Oh, that would be cool.
Yeah, we haven't talked
Yeah.
about it.
But let's just have a go and sort of rate yourself. How are you doing in your area in terms of the quality of the adult sickle cell medical home?
When you say medical home, you mean whatever care we're providing, not a specific.
I'm not gonna answer that for you. I'm gonna let you decide what you think the medical home is. Now, you can't tell it, but there's two kinds of data showing up there. The slide bar shows you the average of everything in the room. But behind the slide bar is what we call a histogram. And it tells you how many people are saying it's piss poor on the left-hand side. And then there's a whole clump of people who say it's 5 or greater and so it's low soft. You see that? That little pale blue thing? All done?
3 more people.
3 more people? Yeah. Tiffany, how does this strike you? Are you surprised? Is this what you expected?
I'm surprised.
Tell me how you're surprised.
I'm surprised that the majority of people are average now. I would think that it would be in between 1 and 3. In all honesty.
Anybody else want to comment on that?
That might be indicative of like me not knowing on the spectrum where I really am in regards to what our program actually has. So once I'm done on Thursday, I might.
Okay.
I'm much slower than that.
You've also got a room full of people who are
selection bias. The best of the best are in the room.
Excuse very much on the higher side.
But it's interesting. So we got the best of the best in the room, but many of the best are still only caring for between 1 and 5 patients. Do you start to get a picture of what the challenge is here? You got all this knowledge in a small little thimble, and it's sort of like a black hole. It's stuck in there, and you gotta explode and let it get out to the places where it needs to. That's why I'm a big fan of this hub and spoke model. Okay, what's next? So I just want to walk you through, one of the reasons why we did that survey at the beginning is I wanted you to sort of identify where you are on your level of engagement and expertise in sickle disease. We developed this in 2014 to try to identify where the hot spots are for patients with sickle cell disease in terms of care, expertise, and quality of care. And we came up with 4 levels. First level is, I don't care. Right? I don't want to be involved in it. I'm as snug as a bug in the rug. I got 1 patient, maybe 0. That's not what I do. Sickle cell, not me. Next level. Okay, I'll take care of a patient. I'll take 1 or 2. And maybe I'm a primary care doc, maybe I'm a hematologist, but I want to learn. I'm willing to learn. I want to learn how to prescribe hydroxyurea, but I don't know a whole lot about what's going on in the literature or what best practices are. And I have to call people because I get all these things happening and I don't know what to do about them. Level 3, pretty high volume. People are starting to come see me, and I have a bunch now. And I'm comfortable trying to take care of those patients. I know about guidelines, but I still don't have a huge volume of patients. I'm somewhere less than 25. And level 4 would be what I'd call a true hub kind of a person. Expert, more than 25 patients, trying to go after more, and giving advice to people, and very, very often sought for consultation. Imagine where you are in that spectrum, and think about what we're trying to do in this conference and conferences like it. We want to turn the 1s into 2s. We want to turn the 2s into 3s, and in some cases, some of you need to be here. So, sort of a goal that we're trying to get to. Any questions about the hub and spoke model in particular, or about some of the things I've talked about? Comments? Yes.
All the statistics that you just told about other doctors and ASH, it seems like there's a lack of interest or concern or care directed towards sickle cell population. Exactly what can be done to
saying that you're disappointed that somebody who took a Hippocratic oath is not wanting to care for some group of patients when they see a need, doesn't want to meet the need, right? Isn't that what you're saying? And I think we all are disappointed that way. I think the medical profession, and ASH in particular, let's be honest, ASH as a society, the American Society for Hematology, blood diseases, paid no attention to sickle cell disease until about 5, 6 years ago. So ASH has its own repentance process that it is going through. If you go to a meeting now, you will see sickle cell plastered everywhere. On the escalators, they had a sand sculpture. Oh my God, it's like manna falling from heaven. I didn't know how to handle myself. 20 years ago, I didn't bother going. Wasn't nothing for me there. So we are changing our ways, trying to change attitudes. And if you're a teacher, you know the 3 major things that you're trying to change when you teach are what? Knowledge, skills, and that last word, the big A word, attitudes. In this case, I think the first thing we have to change is attitudes so that people want knowledge and skill. And we're at the beginning road of that process. And I'm sorry that you're disappointed, but we are too.
What I'd like to know is what can be done to make them.
You want to answer that one? She says make them. Well, but I want you guys are in the field, your community health work, community-based organization. Can you make them? No. I don't think you can. Yes.
So as the communications coordinator for Synergy via Hopkins, what sometimes I do is I'll go and with another professional for sickle cell disease, and we'll go talk to residents and like nurses, high schools, to talk about sickle cell disease, to tell them, give them a face and let them know that that care is needed to maybe help them maybe want to focus on hematology and sickle cell disease. So I do that in Maryland.
Yes, ma'am.
Is it an issue of money or?
Yes, it
an
is.
issue of
Yes, it is.
Right.
Yes, it is. You get way more money for caring for cancer patients than you do caring for either sickle cell patients or rare blood disease patients. You get way more money caring for cancer than you do for that. Yeah. I'm sorry, I didn't let you make your point. Go ahead.
I just had an overall comment. I've been a parent of a sickle cell patient for 16 years. And in that time, my engagement has gone up, basically because of exposure. But even with that connection, these last maybe 2 years, I have only been exposed to this level of information within the last 2 years. So I'm happy that that's happening. And because my wife is so connected, I have somebody that I live with who deals with it every day. But if I think about people like me who may care but don't have that exposure, it's kind of disheartening. So as we move forward with this, I hope to be able to be a stronger advocate, but at the same time, make more connections with all of you and see how I can support, other states, other areas, other organizations.
Yes.
So a comment and a question. I'm going to ask that question first. With the list that you gave of the different tiers of involvement, I wanted to get your opinion on where would you see patients, parents, advocates on that list as in terms of
I think being a patient or a parent does not entitle you to be any particular place on that list. I mean, I think you can be very lonely and be the only sickle cell patient you know. I think Alaska has one. So image of sickle cell disease is, yeah.
Okay, and then, my comment was, so I totally get what you're saying, because my oldest is 18, and it's only within the past 5 years or so that I've really been, well, this level of information, has really been, available to me. And I seem to think that my children, have a really good oncologist, but yet, I don't see her or her staff in any of the bedside checks. So now I'm starting to question that. But I also wanted to make the comment that the individual over here said about you're just a parent. I don't think we should ever belittle the fact that we're just parents.
You're an expert.
And even if we might, our patient or the person that we know is just our own child, we know that child. We're an expert on that. And so I just, wanted to make a plea that even though there is that loneliness and there is that sense of isolation because it's just you and your child, you're your child's parent. And we're all our children's parents.
Yes.
The parent advocates in that room, the parents that are in that room.
Yes.
That's our role.
So what you're going to get as the expert on your child, what you're going to get the next couple of days is, well, what about the rest of the country? Not just what can I do for my child, but what can I do for the rest of the country who's like my child, and how can I get involved with the Army, people who want to do something. I think my time is up. So, Dr. Lapato?
Shirley?
Or is it Shirley?
Shirley.
Okay.
No, you have. She has something. Yeah.
Go backwards. They say go backwards.
I hope, yeah. You're doing it right there. Right there. All right. Yes, I do. Yeah. She told me.
These two versions of the plastic
I don't want to rule the experts.
Okay. So one of the things that I wanted to talk about was just give an overview of a conference that was funded by GBT. And it was really looking at how can we increase access to individuals with sickle cell disease. How can we increase their access to comprehensive health care? And what they did, they got together experts really across the different academic centers in the US and really sat down and looked at what are the barriers, what are the areas of opportunity. So essentially, if you are sitting in a medical institution in a clinic with 20 patients and you feel like you're kind of there by yourself struggling through all of this, and you say, I wish I had an infrastructure. I wish I had a clinic that was dedicated to sickle cell disease. How do you get that going? And so that's what this conference was about. They had one last year, and I think they had one this year too. And they broke it up into 3 big areas. One was just kind of like starting from the ground. You have nothing, you want to build something. The next one was, how do you use the infrastructure that's already in your institution to pivot and begin to serve and care for the population that you serve and care for, and really bring that population in under their umbrella. And then the third part was about the pediatric adult transition. I'm not going to talk about that because I believe Dr. Sisler is going to mention that really in depth. And reading this kind of hit home my experience in Minneapolis. So in Minneapolis, when I went there, back there, because I did my residency there, I got a phone call from one of my mentors, and he said, would you be interested in taking care of individuals with sickle cell disease? I did my medical training at the University of Minnesota. I probably saw 8 patients with sickle cell disease when I was in residency, when they were admitted in the hospital. Never saw a single one in the clinic. There was this adult hematologist, hemonc doctor, Obina Nwaneri from Nigeria. He's now, I believe, in Iowa. And he wanted to open up the only adult, well, actually, the only sickle cell clinic in all of Minnesota. And the first thing that this conference talked about is identifying a champion. You want to identify a champion who is really going to take this on. And this champion, in most instances, ends up being a physician or a healthcare provider, but it does not have to be. It can be a parent. It can be a social or political leader in the community. But you really want to have a champion, somebody that says, this is what I want to do, this is my passion, and I'm going to talk to anybody and everybody, the most important and the least important, to get this done. And Dr. Nwaneri was that champion. He was that champion in Minneapolis. And so he then said, what do I have to do to create this clinic? Well, he's the champion. He has the patients. He has the people that he knows he can take care of. And they're in the institution. Whether anybody wants to take care of them, they see them in the emergency room, they see them in the inpatient side. So you had this champion who could clearly identify, this is the population I want to take care of. And then he looked out to find help. And so you start looking for your stakeholders. Well, in an institution like Minneapolis, the University of Minnesota Medical Center, who are the stakeholders? Who are the stakeholders anywhere? Well, one, obviously the patients are clearly stakeholders. But then within the institution, you have the emergency department. They are huge stakeholders because they see the patients. Many times they see the patients more than you may see them. There's the inpatient providers. They're stakeholders. And so what Dr. Nwaneri did was he looked at the stakeholders within the institution and said, okay, you guys see all of these patients in the emergency room. You complain about the care. You complain about the frequency of them coming to the emergency room. When they come to the inpatient side, everybody feels and everybody knows that they get relegated on the hematology oncology service. So in Minneapolis, in Minnesota, the patients were admitted on the hematology oncology service. So as a resident, the few times that I was on that service, that is the only time I took care of somebody with sickle cell disease. And that was a service that had somebody with acute lymphoma, acute leukemia, and oh, by the way, this person has sickle cell disease. So you can just imagine what message I was getting, clearly and unspoken, about who was the most important patient on my list. It wasn't the patient with sickle cell disease. It was the patient with acute leukemia. So he said, listen, we see how patients are treated here at our institution. We are not proud of it. We know we can do better. So he talked to the emergency department, he talked to the inpatient department, and finally got to the point where got to the administration. And the administration said, okay, fine. We are going to find you another provider, and we are going to dedicate part of his academic salary to working in your clinic. And that's where I came in. Now, not knowing anything, honestly, about sickle cell disease, why would somebody like me say, okay, I would do it? Well, my mentor knew me well. He knew what I did before in Boston, which was essentially taking care of homeless individuals, taking care of patients who were homeless, who had addiction, who were homeless, who were transgender. And what he identified was, this is somebody who cares about the marginalized. But in particular, this is somebody who doesn't mind delving in a segment of healthcare that is completely neglected. And on top of that, strives in that setting. And that is what you want to look for, not just in a champion, but in the people that are going to surround the champion. Because the champion can get the big stakeholders at the table. But what they then will turn around and look and ask of the champion is, well, where's your army? Where's your posse? Where's your gang? Who's going to do all this great work? Because we're going to give you this slice of money and you got to make it work. So what this conference talked about is finding a champion. And then when you're talking to the emergency room department and to the inpatient department and really to the administration, is trying to be able to quantify what is the cost to the institution? What is the cost to the emergency department? Because the reality is, whether it is sickle cell disease, HIV, breast cancer, hemophilia, cystic fibrosis, somebody may raise their hand and say, I would dedicate my life to doing this completely. But the administration, the system, the institution wants to know how much money you're going to save them. What is the cost? And they have to, because they have to keep the lights on. They have to pay my salary and everybody else's salary. So they really talk about making sure that you, when you go to the institution, that they understand what the cost is, what the current cost is, and then what creating a clinic will save them. And really trying to quantify that. And it doesn't have to be very detailed, but it's really getting an idea of how are you going to benefit the institution? Because they aren't just going to simply do this out of the goodness of their heart. They have a business model to run. And one other point that I'd like to mention is that once you get a business plan going, you really want to have an idea of, so you have the population that you want to take care of, then you really want to be strategic about what services you want to offer. And you don't want to bite off too much. You want to be realistic about what it is we can do, how many patients we can take care of, so that when the next year is done and your pilot is through, they will say, okay, you know, you actually did what you said you would do, or a little bit more. What you don't want is to come out through the gate and not hit your mark, because that's going to make it very difficult for them to then give you more money. Thank you.
So what do you all think so far? Having a great time? Okay. So now, throughout the conference, we thought it would be really great to get some really good swag. So each of you, at some point in time in the next 3 days, are going to have some swag. Or maybe. All right, well, let's see who the first winner is. Or not. Brianna Jones. She may not be Ho yet. Nope, no, no, okay. No, you removed her.
Brianna Jones in here.
Ah, there we go.
Next one.
Judy Anderson. You could go pick a bag out of the back there, Judy. I think we're doing 5 at each break. Judith Davis. Is she not here yet? No, she's not here yet. Tiffany. Well, you could go up here or you could go back there. And I think then that gives us one more. Oh, Shamari. Okay, so now remember when I told you we're going to have some breaks and we want you to get up and we want you to move around? I know it's a little tight in here today, but we'd like you to kind of stand up, spread out. Some people can come up here, don't be shy. Dr. Smith is going to be the leader.
Oh, no!
All right, are we ready? You know that we get up?